I'm Dr. Rachel Drew, and today I will be presenting our case of hemophagocytic lymphohistiocytosis secondary to disseminated histoplasmosis. A brief view of our poster, I will be taking us through the introduction, case report, and the discussion of our topic. Histoplasmosis is a common fungal infection endemic to the Mississippi-Ohio River Valley and is caused by the organism Histoplasma capsulotum. Infected immunocompetent individuals are often asymptomatic or experience mild to moderate respiratory symptoms. However, immunocompromised individuals are more likely to experience severe disease and progress to disseminated histoplasmosis, DH. DH has a broad clinical picture, which includes flu-like symptoms, skin lesions, hepatosplenomegaly, and GI involvement. Diagnosis can be achieved through urine histoplasma antigen cultures or serology. Treatment for DH often requires an intense and prolonged course of antifungals, typically amphotericin for several days, followed by itraconazole for months. Hemophagocytic lymphohistiocytosis, HLH, is an excessive immune activation and inability to appropriately restrict immune responses of activated white blood cells and can be life-threatening. Secondary HLH can be caused by infection, malignancy, or rheumatological disorder. Patients often present with acute or subacute febrile illness. Diagnosis of secondary HLH is confirmed by the HLH 2004 diagnostic criteria, which focus on fever, hepatosplenomegaly, cytopenias, hypotriglycerides, and other diagnostic criteria. Treatment is focused on preventing organ failure. Mild cases can be closely monitored with underlying disease treated, whereas moderate cases may need treatment with immunosuppression and steroids or chemotherapy, and severe cases may require stem cell transplant. Today I will present a case of secondary HLH from DH in a 58-year-old woman who initially presented with vague GI complaints as well as fever, chills, and night sweats. The 58-year-old female had a past medical history of rheumatoid arthritis on methotrexate and Humira, Sjogren's disease, hypothyroidism, and was status post cholecystectomy 1 month prior to presentation. She presented with 3 months of worsening abdominal pain, distension, as well as fever, night sweats, and fatigue. On admission, she was febrile, tachycardic, and mildly hypotensive. Exam was notable only for abdominal distension and the hepatosplenomegaly. Labs showed a sodium of 123, calcium of 7.1, alk phos of 477, ferritin 527, bilirubin 7.1, hemoglobin of 10.3, and a thrombocytopenia of 51. CT imaging was concerning for enteritis and revealed several mildly enlarged lymph nodes in the mesentery and retroperitoneum. While the patient was stable throughout hospitalization, she continued to have abdominal pain, distension, and periodic fevers. Her autoimmune workup was unrevealing. An initial infectious workup for bacteria or virus was negative. A fungal workup of a histoplasma urine antigen was positive. An EGD with flex sigmoid was performed with biopsy. The biopsy showed macrophages with GMS-positive yeast forms. Due to her thrombocytopenia, we performed a bone marrow biopsy, and that showed histoplasmosis and rare macrophages with hemophagocytosis. Using the HLH 2004 diagnostic criteria, she met diagnosis of HLH. She was treated with amphotericin for the histoplasmosis dissemination, and the HLH was closely monitored without direct immunosuppressive treatment. Here is the imaging from the EGD biopsy. The explicit results from the hemopathology result of the bone marrow biopsy, which showed rare macrophages with hemophagocytosis. Our discussion. Disseminated histoplasmosis is an uncommon infection with a challenging diagnosis. For immunocompromised individuals, fungal infection should always be considered in the differential diagnosis. Furthermore, in patients with systemic inflammatory symptoms, febrile illness, liver abnormalities, and cytopenias, the diagnosis of HLH should be considered. While HLH is a rare syndrome, prompt diagnosis and treatment are crucial for preventing mortality. Careful consideration must be taken when managing HLH in the setting of infection, such as disseminated histoplasmosis. While immunosuppression or stem cell transplant can be used to prevent organ failure and mortality in HLH, mild cases can be managed with supportive treatment and treating the underlying disease. Here's the bibliography of the sources we cited. Thank you for your attention.